Students, now we will talk about the intrauterine growth restriction, or previously which was also known as intrauterine growth retardation. Okay. Now firstly, what is the difference between IUGR and small for gestational age baby? Okay. So intrauterine growth restriction, this is more of a clinical definition, and SGA, small for gestational age is more of a statistical definition. Because when we label a baby as IUGR, it is irrespective of the gestational age. But small for gestational age baby, we all know this is less than 10th percentile for that gestational age. So students, in short, all the SGA babies are IUGR, but all the IUGR babies are not SGA. Okay. Next, when we talk about the clinical definition of IUGR, it includes presence of the more than equal to 3 buttock folds, loss of subcutaneous fat and peeling of the skin. Okay, so such kind of baby are known as intrauterine growth restriction. Okay, now IUGR baby is of two types. There is a symmetrical IUGR and there is a asymmetrical IUGR. Again, very important, students. A lot number of MCQs are being asked from this topic. So symmetrical IUGR happens when the insult to the baby occurs in the early phases of intrauterine life, and asymmetrical happens when the insult occurs in the late phases of intrauterine life, leading to a brain sparring effect. Okay, so in the early phases, what all insults can be there? There can be genetic problems, chromosomal issues, or Torch group of infections. And in the late phases, mainly there is uteroplacental insufficiency leading to the asymmetrical IUGR. Now, as I told you, in symmetrical IUGR, there is head is also involved, so there is a proportionate equally involvement of the head, the weight and the length of the baby. But in asymmetrical IUGR, because of the brain sparring effect, the head is relatively large as compared to the length and the weight of the baby. Okay. Next important point is the Pondral index. So students, you must be remembering this index. They can give you an example like the weight of the baby is this and length of the baby is this. What is the Pondral index, or what is the baby according to the Pondral index? The baby is a symmetrical IUGR or a asymmetrical IUGR. Any such kind of question can be given. Okay. So Pondral index, students, is weight in gram divided by length in centimeters cube multiplied by 100. This is Pondral index, and the Pondral index of more than equal to 2 suggests a symmetrical IUGR, and less than 2 is asymmetrical IUGR. Okay, so students, as you know that because of the involvement of the brain, the symmetrical IUGR babies have a poor prognosis, but asymmetrical IUGR babies have good prognosis. Okay, so this is about the symmetrical and asymmetrical IUGR. Now when we talk about the problems that are associated with the IUGR babies, is first is the intrauterine fetal demise. Second is the high chances of the meconium aspiration syndrome. Okay, because they have a fetal distress. Okay. Number third is they have a high tendency of hypoglycemia, hypothermia. They have a very poor weight gain, feed intolerance, and high risk of perinatal asphyxia. Okay, so students, you must be remember all these problems that are associated with the IUGR baby. Now we will talk about the preterm babies. Okay, so I told you that the preterm baby is any baby that is born before 37 completed weeks of gestation. Then that baby will be labeled as preterm baby. Now assume in this case the baby is born, but the gestational age is not known to the mother. The mother does not remember the LMP and you don't know the gestational age of the baby. So in that case, how to assess the gestational age of the baby? Okay, for it we have a score that is known as expanded new Ballard score. Okay, expanded new Ballard score, ENBS. So this is the name of the score which helps in assessment of the gestational age of a newborn. Okay, and it assesses the gestational age from 20 weeks to 44 weeks of the newborn. Okay, and the accuracy is plus minus 2 weeks. So in this score there are two components are present. Number first is the neuromuscular maturity and number second is the physical maturity. And within the neuromuscular maturity, then there are 6 other components present, similarly in the physical maturity. Okay, and then the score is given from -1, 0, 1, 2, 3, 4 and 5. The score is given like this. The minimum score is -10, which corresponds to the 20 weeks of gestation, and the maximum score that comes out is 50, that corresponds to 44 weeks of gestation. Okay, for each rise in score of 5, the gestation increases by 2 weeks. So this is expanded new Ballard score. Now students, I'll be explaining some physical maturity features through which you can assess that the baby is a term baby or a preterm baby. Number first is the posture. The posture of the preterm. The preterm baby has a posture of hypotonia. As you know that the term baby have a posture of flexion. So this attitude of flexion in upper limbs and lower limbs is not present in the cases of the preterms. Okay. Number second is skin. Their skin is shiny gelatinous skin. Okay. There is loss of the subcutaneous fat. Abundant lanugo are present. Vernix caseosa, that is the whitish colored substance that is present on the body of the baby, is scanty in these babies. Okay, their head is relatively large as compared to the body, and their anterior fontanelle is large and widely open. So this is about the head. When we talk about the ear, their ear cartilage is poorly formed. Okay, so soft pinna is there, ear cartilage is not formed up to the periphery. Now, when we talk about the breastbuds are small or absent in the case of preterms. These are less than 5 millimeter in size. Okay, now let's talk about the genitalia. In the male genitalia, the scrotum is poorly formed. The testes can be undistended, testes can be present, okay, and the rugae is not present and the hyperpigmentation is not present in the scrotum. In the female genitalia, the labia majora is widely separated, exposing the labia minora, and there is presence of clitoromegaly in response to the maternal estrogen. Okay, so this is present in the female genitalia. Now, when we talk about the plantar crease, so no deep creases are present, the faint marks are present on soles. When we talk about the hair, fuzzy hair are there that are present in preterms, while in terms, silky hair are present. So students, these are some important physical features on the basis of which you can differentiate the baby is preterm or a term baby. Okay. Now students, when we talk about the feeding in preterm babies, some important points to remember. Again, an important MCQ. So less than 28 weeks gestational age baby. Okay. So in this case, their sucking reflex is not properly developed. Okay. So you have to start with the IV fluids in this patient. Now, from 28 to 31 week baby. Okay, so these babies have poorly developed sucking swallowing reflex and breathing coordination. So, in these babies, orogastric tube feeding is to be done. Okay, in babies from 32 to 34 weeks of gestation, now their sucking, swallowing and breathing coordination slightly develops, and you can start with a Katori spoon feeding, or you can say a Paladay feeding. Okay, and the babies more than equal to 34 weeks of gestation can be started with the breastfeeding because their sucking, swallowing and breathing coordination is properly developed. Okay, so this is about the feeding in the preterm babies. Students, now when we talk about the problems that are associated with the preterm babies, number first is the problem associated with the central nervous system. So the problems are, there is intraventricular hemorrhage, periventricular leukomalacia, and very important is the retinopathy of prematurity. Okay, then let's talk about the respiratory system. So there is hyaline membrane disease, also known as the respiratory distress syndrome. there is apnea of prematurity, bronchopulmonary dysplasias, or there can be pneumothorax. Okay, so these are the problems that are specifically associated with the preterm births. When we talk about the gastrointestinal system, then there is necrotizing enterocolitis and hyperbilirubinemia because of the decreased maturation of the glucuronide conjugation system. Okay, so these are the gastrointestinal manifestations that are commonly seen in the preterm infants. In the cardiovascular system, you have patent ductus arteriosus, okay, and you can have bradycardia because of the apnea. Okay, so these are specifically pertaining to the preterm babies. Then there can be the presence, they catch the infections more, sepsis, presence of sepsis is more commonly seen in the preterm babies. Okay, then hypoglycemia, hyperglycemia, hypocalcemia, these are more commonly seen in the preterm babies. Okay, so these are some important problems that are associated with the preterm birth. Also very important problem is hypothermia. As I told you that neonatal hypothermia is defined as axillary temperature of less than 36.5 degrees Celsius. Okay, now how to manage hypothermia in preterm? According to the neonatal resuscitation guidelines of 2015, all the neonates who are born in less than 32 weeks of gestation should be wrapped in a polythene wrap and thermal mattresses should be provided to them. Okay, the babies who are less than 32 weeks of gestation, the thermal management is done in an incubator. So new incubators are best for the preterm babies less than 32 weeks of gestation, and radiant warmer provide a good care for the newborns more than 32 weeks of gestation. Okay, so this is about the thermal management in a preterm baby. Also, next important part is the kangaroo mother care to be given in all the stable low birth weight babies. Okay, in the preterm neonates, you have to maintain their oxygen saturations between 90 to 95%. So these are the target limits, above which there are high chances of retinopathy of prematurity and oxygen toxicity. Okay, now when we talk about the retinopathy of prematurity, students, this is the vasoproliferative disorder of the retina. Okay, and whom to screen for retinopathy of prematurity is very important question, and MCQs are being asked on this question. So all the neonates less than 32 weeks of gestation, all the neonates less than 1500 in grams, or the sick newborns of more than 32 weeks of gestation, or the newborns having a turbulent NICU stay. Okay, more than 32 weeks gestation but having a turbulent NICU stay. So these neonates should be screened for retinopathy of prematurity. And when to screen these neonates is again a question. So the neonates, the first screening should be done at the 4 weeks of postnatal life, or at the 32 weeks of post-menstrual age, or after 4 weeks of postnatal age, whichever is later. Okay, so this is the time when first screening should be done in the cases of retinopathy of prematurity. So this answers the most of the questions that have been asked on retinopathy of prematurity.